Welcome. Today, we are diving deep into a high-yield clinical review of diabetes mellitus. Whether you're a medical student just starting your internal medicine rotation or a resident right in the thick of it, this is going to be your guide to the modern, up-to-date approach for one of the most common conditions you'll ever see. So here's our game plan. We're going to follow the entire clinical journey from start to finish. We'll kick things off with a why, the whole reason we screen in the first place. Then we'll nail down how to make that definitive diagnosis, how to set smart, individualized goals for your patients, and finally, we'll get into the really exciting stuff, the latest in medications, which has just completely changed the game in the last decade. Okay, let's jump right in. The very first question we have to tackle as clinicians is this. In a busy clinic, why on earth should we be proactively looking for diabetes in people who feel totally fine?
And it's a really good question, right? We don't just screen for everything under the sun. So what is it about type 2 diabetes that makes it different? Well, the answer really gets to the core of what preventative medicine is all about and why getting ahead of this disease is just so critical.
Okay, so here's the deal. Type 2 diabetes has this incredibly long silent runway. For years, literally years, a patient can be walking around feeling completely normal. But all the while, that microvascular and macrovascular damage is already starting. It's happening under the surface. So screening lets us peek behind the curtain and intervene during that critical window. And the best part is, we have interventions that work. We can actually prevent or delay the progression from prediabetes to full-blown diabetes. And if we do find it, starting that intensive control early just dramatically slashes the risk of those awful long-term complications down the road. Now, when it comes to who to screen, things get interesting. You've got two major players in the U.S. with slightly different takes. The American Diabetes Association, the ADA, they cast a pretty wide net. They say, look, screen any adult who's 35 or older, period. Or if they're younger but have a BMI over 25 plus at least one risk factor, like a family history, screen them too. The U.S. Preventive Services Task Force, the USPSTF, is a little more focused. They target adults between 35 and 70 who are overweight or obese. The good news is, they both pretty much agree that if the results are normal, rescreening every 3 years is a good move.
All right, so you've made the call to screen your patient. What happens next? Well, you need to know exactly what those lab results mean. This part is all about turning those numbers into an accurate, confident diagnosis.
This table right here, this is your bread and butter. You absolutely have to have these numbers memorized. For an A1C, the magic number for diabetes is 6.5% or higher. For fasting glucose, it's 126, and for that 2-hour glucose challenge, it's 200. Now, there is one big exception. If you have a patient with those classic symptoms, drinking tons of water, peeing all the time, and their random glucose is 200 or more, that's it. You've got your diagnosis, no confirmation needed. And remember, our whole goal is to bring these numbers down safely, always walking that fine line to avoid pushing them too low and causing dangerous hypoglycemia.
So, which test should you actually order? The classic clinical dilemma. The hemoglobin A1C is awesome for the patient. No fasting, super convenient, but it's a bit less sensitive and can get skewed by things like chronic kidney disease or certain anemias. On the flip side, the fasting plasma glucose is cheap and every lab can do it. But you're asking your patient to fast for 8 hours, and it's just a single snapshot in time. It can bounce around quite a bit from day to day. And this brings us to an absolutely critical safety point. Outside of that slam dunk case with a symptomatic patient, you should never make this lifelong diagnosis based on one single number. It's just not safe. If you get an abnormal result in someone without symptoms, you have to confirm it. You either repeat the test on a different day, or you show 2 different abnormal tests from that very same blood draw. This simple step prevents a huge amount of heartache from a lab error or just a random fluke. Okay, so we've got the diagnosis. Now comes the part that's more art than science. What are we actually trying to achieve? It used to be that we had one single goal for everybody, but thankfully, modern diabetes care is way smarter and much more personalized than that. This is the new mantra. Seriously, we are not treating a number on a lab report. We are treating the human being sitting in front of us. A 40-year-old who's otherwise healthy is a completely different universe from an 85-year-old with heart failure and kidney disease. Their goals have to reflect that reality. And this table really brings that idea to life. For that young, healthy patient, we're aiming for tight control, right? An A1C below 7%, because we want to prevent those long-term complications over their long life.
But for a more complex patient, someone who already has complications, maybe a shorter life expectancy, and especially a high risk of hypoglycemia, we relax that goal to less than 8%. And why? It's all about risk versus benefit. For that patient, the immediate danger of a severe hypoglycemic event, a fall, a seizure, a trip to the ER, that harm can be far greater than the theoretical long-term benefit of squeezing that A1C down another half a point. It's about being smart and safe.
This brings us to our grand finale, treatment. And let me tell you, this is the area of diabetes care that has been absolutely revolutionized. The whole goal has shifted. It's not just about lowering the A1C anymore. It's about protecting the heart and protecting the kidneys. This quote right here says it all. The choice of which diabetes drug to use is now driven by what else is going on with the patient. Do they have heart disease, kidney disease, heart failure? The answers to those questions are what guide our hand now, sometimes completely independent of what the A1C is.
And wow, this table just brilliantly illustrates that point. Look at this. The two rockstar classes right now are the GLP-1 agonists and the SGLT2 inhibitors. These drugs do so much more than lower sugar. They have proven hard data benefits for the heart and the kidneys. And SGLT2 inhibitors, they are an absolute game changer for patients with heart failure. It's a massive paradigm shift. And you want to know the best part? They do all this incredible work with a very, very low risk of causing hypoglycemia, which is a huge advantage over older meds.
So what does this actually look like in clinic for, say, a high-risk patient with known heart disease? Well, the foundation is always going to be lifestyle changes in metformin. But step 2 is where everything changes. It's no longer just add whatever. The guidelines are crystal clear. You add an agent with proven benefit. That means a GLP-1 or an SGLT2. The choice is all about organ protection, not just dropping the sugar a little more. So let's boil it all down. What are the key takeaways? First, metformin is still king for first-line therapy. It works, it's safe, and, critically, it doesn't cause hypoglycemia, making it the perfect foundation. Second, and this is the big one, comorbidities drive your next choice. If your patient has heart disease, heart failure, or kidney disease, a GLP-1 or an SGLT2 is the right call, even if their A1C is already looking pretty good. And finally, don't just set it and forget it. You have to reassess every 3 months if they're not at goal and be ready to intensify their therapy. And that really leaves us with a final, fascinating thought. We've gone from a world totally focused on glucose to one focused on organ protection. The very meaning of good diabetes control is changing right under our feet. So the big question for the next decade is this. As these incredible therapies get even better, will we eventually stop thinking of diabetes as just a blood sugar disease and start treating it as a global cardiovascular and renal risk state that we can truly manage and modify? What an exciting time to be in medicine.